I want to thank all of you for coming and being part of our presentation today. On behalf of the National Health Council, I want to thank everyone for logging in, and I want to greet everyone and provide a welcome. So, the National Health Council, the featured presentation is Understanding Cognitive Health in the Lifespan. My name is Dr. Karen Mancera Cuevas. I'm the Senior Director of Research Advancement and Equity at the National Health Council, which provides a united voice for nearly 200 million people across the United States living with chronic diseases and disabilities and their family caregivers. Our membership includes more than 180 national health-related organizations and businesses, including the nation's leading patient organizations. This presentation on cognitive health is sponsored by Eli Lilly and Company. Thank you all for making the time to join us today. Okay. Now here we provided a survey QR code. So please take the time to complete the survey before the start of the presentation. We want to thank you so much. So this survey really is to determine your knowledge in the cognitive assessment and cognitive space before we start today's presentation. So I'm going to provide approximately 1 minute's time in order for participants to complete this survey. Should be very quick, less than a minute, and there's approximately 5 questions. So we've also provided a link to the survey in the chat for those that cannot access the QR code. So please, again, look at the QR code to answer the questions, and a link to the survey has also been included for those who need abilities to access the survey. But the survey will really assist us to determine understanding within the cognitive space. Now we're going to move on to more housekeeping. So we're going to review housekeeping items, a few quick housekeeping notes before we begin. So this meeting is being recorded and made available after to all NHC members and the public. No AI-powered note takers are permitted on any NHC virtual meetings unless approved prior to the beginning of the meeting. If you have any questions or comments, please use the Q&A. During the Q&A, the webinar host will unmute you if you wish to ask questions aloud. When prompted, you will have the opportunity to participate in the survey. If you have any questions with the Zoom links, technical issues, or agenda, please email me directly at kmcuevas@nationalhealthcouncil.org. And the NHC does not endorse certain products for therapeutic use. Moving on to our featured panelists, and we have an illustrious group today, so I'm very excited to hear more from our panelists today. I'm going to introduce you to our panelists. First, we're going to start off with Dr. Darby Morhart, who is professor at the Missoula Institute for Cognitive Neurology and Alzheimer's Disease at the Department of Medicine, Northwestern University Feinberg School of Medicine. We're also joined with by Dr. Raj Shah, who is professor in Family and Preventive Medicine at Rush Alzheimer's Disease Center. In addition, Dr. Shelley Williams has joined us today, and she's a physician and associate professor of geriatric and palliative medicine at the University of Chicago. And lastly, we are joined by Vicki, who is living with early onset Alzheimer's disease, and her husband, Robert, who will share their experience alongside with their son, Rashad, on navigating her diagnosis, research participation, and impact on the family. For conflict of interest, Dr. Raj Shah reports in the past 3 years being the site principal investigator or sub-investigator for Alzheimer's disease clinical trials and observational research sponsored by Eli Lilly and Company, for which his institution, Rush University Medical Center, is compensated. Now we're going to discuss issues for what is brain health. So this conversation, before we do a deep dive into our topic of today, is really level setting of what is brain health and what background we need to really understand before having conversations with our panelists, with individuals with lived experience, so we better understand this process more. So brain health refers to how well a person's brain functions across several areas, and aspects of brain health include cognitive health, which is how well you think, learn, and remember. It includes motor function, which is how well you make and control movements, including balance. Emotional function, which is how well you interpret and respond to emotions, both pleasant and unpleasant. In addition to tactile function, which is how well you feel and respond to sensations of touch, including pressure, pain, and temperature. Sensory function also encompasses a lot of these elements in terms of aspects of the brain, which is how well you see, hear, taste, and detect odors. Brain health can be affected by age-related changes in the brain, injuries such as stroke or traumatic brain injury, mood disorders such as depression, substance abuse, or addiction, or diseases such as Alzheimer's disease and related dementias. And related sources have also been provided on behalf of the National Institute on Aging on this resource. So we're going to move on to the next slide. It's important that we also understand about cognitive decline facts and caregiving implications. About 1 in 10 adults 45 and older report worsening memory loss or cognitive decline, and another 1 in 4 report caring for someone who has cognitive impairment. Dementias like Alzheimer's disease start with mild memory loss and can lead to an inability to carry on conversations or response to one's environment. As our aging population grows, so does the need for public health strategies to reduce the impact of dementias and raise awareness of caregiving as a public health issue. And the reference here is from the CDC. So key highlights for today's session includes understanding the role of social support for families, patients, and caregivers. A lot of this is going to be at the core of what it is that we're going to have in our conversation today. It also includes connecting lived experience with patient decision-making. How do patients really go through the decision-making process? And the Johnson family can share with you their lived experience about what that looks like. Reviewing challenges of individuals encountering cognitive decline associated with Alzheimer's or dementia is going to be part of today's conversation, not only from the academic expert panelists, but also from lived experience and conversation. Describing pathways to treatment and care for patients facing coexisting conditions is very important and will be a lot of the highlight of Dr. Williams' conversation and what that looks like. Discussing the vital role of early detection through cognitive assessment and treatment. What does that look like? I know that there's a lot of conversation on this topic, and we'll learn more today from our experts into what are implications associated with that. And lastly, highlighting how research has informed our understanding of cognitive health and future directions. There's a lot to unpack here, and we're definitely going to be enhancing that conversation. Here is going to be one of the most important parts of our talks today, Vicki, Robert, and Rashad Johnson's lived experience. Now we will transition the conversation over to Dr. Morhart, who will ask questions of Vicki, Robert, and Rashad on their lived experience.
Thank you, Karen. And hello, Vicki, Robert, and Rashad. Now I'm not able to see you. Oh, there you are. There you are. Good to see
I
you.
am.
Here you are. Good to see you all. Thank you so much for being here today and for, again, sharing your story. It's so important for everyone to hear your story of, and I'm going to start with just Tell us about what led you to seeking an evaluation for changes in your memory and thinking. Whoever would like to begin.
I'll start.
Okay, good.
Um, Actually, I just well, let me go back a little bit. My grandmother um was living with my mom. My mom was her caretaker, and we went to go visit her, and we hadn't seen her in maybe about a year. And when I went to see her, she looked totally different. She didn't know who I was. Um, and I didn't know what was going on with her. And so, I asked my mom, and she said, well, she has Alzheimer's. So that was my first um, acknowledgement of what Alzheimer's was. And
Mhm.
it was pretty scary because I wasn't prepared for it. Um, so a few years later, she ended up passing away. But then in, I would say 2023, 2022, 2023, somewhere around there, I started noticing that my work at work was becoming subpar. And I was being called in the boss's office a lot more often than I was before. And so I knew something was going on because I kept making mistakes, forgetting things like that. Um, so I contacted a neurologist at Northwestern, and we did some counseling. And he had me start out with the counseling, and the counseling did help somewhat. After that, he had me go to a speech therapist. So I did the speech therapist for about 6 weeks. And I mean, that did help in some way, but it didn't help by why I was doing some of the things I was doing, forgetting so much and things like that. And then I went back to the neurologist. And then finally, I had heard about this OP, is it OPA? What is, I think I wrote it down. OPAE gene,
The ApoE gene.
APO gene, yeah.
Mhm.
And so I just asked the neurologist, I said, can you just give me a APOE test, a blood test, a spinal
Mhm.
tap? So since I went through all the things he had me go through, he said yes. So he did a spinal tap, and then he found out that I did have that gene. So at that point, he knew I was in the early onset stage.
Mhm.
So I went back to work. I let everybody know. And a lot of people were very surprised that I shared that with them. And I was surprised that they were surprised.
Mhm.
Um, but I explained to them I wanted people to know, this was my journey. It shouldn't have taken that long, but, you know, it did. So everybody was very, accommodating. They gave me a party, and I left on good terms.
Mhm.
Um, After that, I just started doing my research on Alzheimer's and started making changes in my diet. You know, no more McDonald's and the Burger Kings, the fast foods, and that had made a total difference in how I was feeling. And then because I wasn't working, I was able to hit the gym often. So my days were then filled with, being able to prepare good foods for me, nothing with no processed foods, nothing like that. Drinking a lot of water, not too many other beverages other than water. Huh? Oh. um, so yeah, so that's basically how that happened.
How that all started. Yeah.
Right. Yeah.
Thank you for sharing that, Vicki. And Robert and Rashad, is there anything you'd like to fill in with as part of that beginning and getting the diagnosis?
Yeah, I can go back to when she she first started to complain about it, and I think that was back in 2022, early 2022, and
She started to complain. What do you mean by that?
well, complained that she made a mistake at work,
Okay.
or she complained that it it was taking her longer to complete a task at work than normal.
Mhm.
And so me, I just, oh well, it's just stress. You know what I mean? Just let's take a vacation. Let's alleviate some of the stress and see what happens. And then I think one of the treatments before she got diagnosed was, I think they did some antidepressant
Yeah.
medication or something like that, um, thinking that that would be, one of the things that would help her with her memory. So, so she started to take that, and then, but it still continued. I tried to alleviate as much stress on her or for her as possible, just so things could get better, because I was in denial too, saying that, oh, it's not that.
Yeah.
Um, but it continued to get frustrating for her, and I could see it. And so she went back to the doctor at Northwestern, and just to add to what she said, she did request a more in-depth test, which was the spinal tap. And yeah, and it did reveal that, those were the findings. Um, and then at Northwestern, we found some really, really great social workers that helped us through this journey, in the name of Dr. Morehart. So, so we appreciate that also. But that was, our lived experience up until she got diagnosed in 2023. So,
Yeah.
yeah.
Thank you, Robert. And Rashad, do you want to add anything here?
Yeah. So
Glad you're here.
thank you.
This is a disease of the family. When you get a diagnosis, everyone's getting this.
We
The
all
whole
go through it
family is, right?
for
Yeah.
sure. Yeah, with me being, what was it, 2023, I was 23 years old. I was really young. And
Mm.
obviously, like, my dad said, kind of in denial, and so because it's fairly new, not just to us, but from what I'm learning, so many people, and it's so undiagnosed. Just me being young, me being in denial, but it was kind of hard to just accept, when you hear, oh, I've got diagnosed with early onset Alzheimer's as only son of hers, it's like I said, new, so I don't really understand how to digest the news. And so I didn't think much about it. Um, and then I didn't really start doing my own personal research until I started seeing more progressions and understanding, and maybe a couple breakdowns from my mom. So trying to understand where a lot of things come from. But over the last few years, I've gained a ton of knowledge about how to be there for her, how to support her, how to make this thing last longer and our time last together. So
Yeah,
Yeah, we
absolutely.
don't argue as much anymore.
yeah.
I'm going to ask you a couple more questions. One is what have been the biggest challenges, but I also want to ask too, what have you found helpful? So maybe start out with some of the challenges now.
For me, I think one of the biggest things was getting lost, not remembering how to get to somewhere where I used to go all the time. I did take the driver's test, had to pay $500 for it. But everything, they said everything was fine, the driving was fine. So that was a little bit of comforting. And then I think just not working being able to do my own research, being able to have the time to myself to figure things out, not being rushed or pushed or forced to, do things I didn't want to do. So those were the hardest things, other people's expectations that I couldn't meet.
Yeah. Huge.
Yeah. And then
Yeah.
I think for us, for me, I was kind of accustomed to her doing things, the way she do things. Very strategic. She's a very strategic person. Everything is in order. She plans a year or two ahead of everything. So that was for me different. But the greatest thing about this thing is that was her prior to the diagnosis. Now she and I spend more time because, we spend more time together because most of the time I'm taking her, places that's unfamiliar to her, but we're still spending time, which is a plus, which we didn't, when we were working. So it's bittersweet. I think it's sweet because we do spend time together, a lot. So yeah. So all of her appointments and all of her conferences and all of her studies and that she participates in, it's a nice journey for the both of us. Yeah.
That's nice. Bittersweet.
Yeah.
Rashad, what about challenges for you? Would you say?
Yeah, so I would say my challenges honestly were more personal because, like he said, you're so used to her raising you and just being perfect, near perfect with everything, and you hold her to a
Vicky,
level high
how
standard.
nice for your son to say that.
Yeah.
So perfect. So, it was more like, in just mid conversations, it wouldn't be anything super over the top, but just she would forget, maybe what I thought was the simplest thing, or how could you not remember that? Or, so it was a little bit in the moment frustrating, but over time, I understood that could have caused a little bit more stress on her because I know she was trying her best. So, just for anybody out there dealing with it, it's, my problems were more personal. So I've become more patient.
He has.
I've become more patient and understanding and mature. Yeah. So those are my problems.
Yeah.
And I get to babysit his daughter almost every day. And so that really lifts my spirit and, gives me a purpose. Yeah.
Very nice. Very nice. Well, what have you all found most helpful along this path here? Who and what has supported you?
You. Doctor, what's my psychologist's name? What's his name? Kahan, Dr. Kahan. Yeah, the conferences. And I was in some program where I had a mentor, I think.
You are the mentor.
Yeah, I was the mentor.
Yeah.
Yeah.
So a medical student.
With the medical students. Yeah. Yeah. So that was a very good experience. And I think I did it twice. I've had 2 mentors so far. Mentees.
Yeah. And for me, just the education that the Alzheimer's Association and the doctors and the researchers provide, for caregivers and individuals living with Alzheimer's. I just found out I was at a conference just last Saturday, and I thought I heard it all, but I heard something different that resonated with me that I heard, but I wasn't listening, So I heard again, and it just reconfirmed, some of the things, the changes to expect, some of the resources that are available to individuals living with early onset Alzheimer's. So those conferences and doctors and researchers has really helped understanding what this disease is all about. So I really appreciate, those conferences and those lessons that they teach. So, and the research.
Yeah. Knowledge, education, so important.
Yes. Yes.
And Rashad, what supported you and what have you found helpful along the way?
I'm available to babysit his daughter.
Yeah. No, honestly, what has helped me is her, which is ironic to say, but just her being patient enough to help me understand what she's going through. She doesn't have to do that, but she's helped me. My dad has helped me kind of just put certain things in perspective because he started spending a little bit more time with her since we're in different homes now. So, just relying on, the people who are going through it the most and just staying connected and close with them has been a huge help.
Thank you so much for sharing this. And Karen, I just want to check in with you on the timing. Can we ask a question about their experience in research? Do we have some
Yes.
time? Okay.
Yes.
All right. We'd love to hear. I know, Vicki, you have been very involved in different research projects around the city. So can you just give us your experience and share your experience with that?
I might need some help with that one. Just remembering, because I think I've been to about 3 or 4 of them.
Yeah. Mm-hmm.
They have been helpful. They have been helpful. I've learned a lot. I talk with the doctors and their assistants to find out, what's going on. I think right now I'm in which one is that, Robbie? In the START study. And that's been pretty much my main study that I've been focused on.
Yeah, we were involved in one at Northwestern back in 2024. I want to say it was. It didn't involve a study drug or anything like that. It was just mostly just observation.
Observational.
It was doing the MRIs and X-rays and things like that, and just kind of keeping an eye on the progression or the non-progression of the disease. So it was the one at Northwestern, and then it was one more at Rush, which was the same thing. It was just an observational study. So this last one that she's been involved in since 2025, I want to say, till now.
Is that the START study?
Yeah, the START study started 2025 and it's still continuing now. It involves a study drug. So that's what we are dealing with now. Right now, we've halted the study drug for a reason, but we're still in the program, for observation at this point. So, but again, the studies has been good for us because it does keep us active, and it keeps us knowledge of what's going on, the progression or non-progression. When she goes through and do all of the cognitive tests and things like that, they'll come back and say, "Oh, it was the same as last year." So that's pretty positive for us, So
yeah.
Mm-hmm.
Yeah, it keeps you in touch. And Rashad, do you have any thoughts about the research part of things? What are some of your thoughts about that?
Yeah, I'm just consistently learning, just staying informed and that's one thing, recently that I've been asking more questions, kind of using AI and Chat GPT to do some research and, see, I recently learned about keeping her blood pressure down and how and how that plays a big part in, minimizing some of her risk and things like that. So just continuing to learn from them, Chat GPT, the internet, you guys. So
Yeah, yeah, yeah. His research is like, how was the research today? That would be his question, you know. So he hasn't actually gone to it, but he stayed, active in finding out how things went at the research, and and we just, teach or tell him
What
so
happened? Yeah.
yes, so he'll have knowledge of it. So
Hmm. Hmm.
yeah, but it's been a good experience with the I feel for the researchers.
Yeah.
Yeah.
Thank you for participating in the research. It's really so important that we keep learning more and more about this disease, how it works, and what we can do to better treat it
Thank you.
and
Thank you.
prevent it in the future. So thank you so much. And thank you for sharing your story with everyone here today. Is there anything else you'd like to share before we move on to
I
our
just
other?
want to shout out Sarah and Elizabeth in the chat. Thank you
Yes.
guys.
Uh-huh.
For sure. For sure. We see you.
Yeah.
Yeah.
Very grateful. Everyone is really grateful for your story. This
Yeah.
is
Yeah.
probably
Thank you.
the
Thank
most
you.
important part of today's session. Thank you for being
Well,
here.
well, thank you for asking.
Of course.
Yeah. Yeah. This was good. That's good.
The only thing I would like to add is that for my wife, for Vicky, um, she, like my son said, perfect. Everyone, oh, Vicky, yeah, she's perfect. She's so, but for this, uh, now, our present situation now is that she's still that person. Nothing has changed. We are aware of what it is, but nothing has changed as far as the way we treat her, uh, um, how she, uh, you know, respond to certain things. We still rely on her for a lot of things, and I'm so proud of her because she still responds in that way. She's always brave enough to say, "Hey, that's not something I'm comfortable with," or and she'll make a joke about, "Oh, I forgot about that," and she'll laugh.
I use that a lot.
And but her sense of humor, is what makes it comfortable for everybody.
Mm-hmm.
We don't have to put on a stigma or treat her a certain way
Yeah.
because the sense of humor is probably 5 times greater than what it was. So I was like, is she funny or what? So but yeah, so that's the biggest plus difference with this what we're dealing with now.
Mm-hmm.
I, I
Yeah.
I love to see her smile and laugh and crack jokes. So
Yeah.
that's where she is,
Yeah. And I know my bestie is on too and listening to this. So she's played a very important role in my journey. So, we always ride together whenever we're driving. We ride together, even though every time we drive, her neck is constantly going back and forth, checking my mirrors and everything. But she's been very supportive. But I still have to also, let her know when I'm going through certain emotions or whatever. So I just want to say thanks, Vanessa, if she
Oh.
can hear me. Yeah.
You're welcome.
Oh.
Wonderful. Thank you. Thank you, Vicki. Thank you, Robert. Thank you, Rashad, for being here today. And shall I turn it over to you, Karen, now?
Yes, definitely turn it back to me. So, such an enlightening conversation to hear from the Johnson family. And as I said, earlier when we started this conversation, we were going to really keep the Johnson family at the core of our discussion today. A lot of the questions that I'm going to be moving on to now will really support their lived experience, but you'll be hearing from experts who can really explain more from their perspective what that journey looks like. So I'm going to be starting off with doing a dive into questions. First, starting with Dr. Morehart. So can you talk about how you work with persons living with dementia and their family caregivers?
Well, I think you just saw a glimpse of that with the Johnson family. I've been a clinical social worker for the past 40 years. I've been working with persons living with dementia and their caregiving families, and most of my work has been in the outpatient clinical setting with a multidisciplinary team. So I'm not going solo here. I'm working with the neurologists, I'm working with the neuropsychologists, the psychiatrists, primary care physicians as well. Families make appointments with the social worker. We have a social work team in our clinic, and usually after the diagnostic workup is complete, to discuss the implications of the diagnosis on their lives, and how they're going to live with this now and organize themselves around it. I always say, if you've gone to the doctors, they're very focused on really teasing out the medical part of this, the diagnosis. I'm more the non-medical person here, and let's focus on how you're going to live with this as a family. And so that really means that I get to know families in a very in-depth way, and try to help them. Well, I really try to get to helping them understand the diagnosis. So I provide a lot of education. We talk about challenges that they may have, and then I also refer them to available services that support them over time. So it's really this combination of counseling, education, and resources.
Very helpful to know. Also, can you describe what people with early memory loss and their families often face prior to getting a clinical diagnosis?
Yeah, it's such a great question, because it's really people living with these early stages of cognitive decline are often living with their symptoms for about 2 to 3 years or more before a diagnosis is made. And I call this the crisis phase of the path here. And this is, I take it from a colleague of mine, Dr. John Rolland, who talks about families and families living with chronic illness. And this crisis phase is a time when there can be a lot of confusion for families, recognizing that things are changing, but they don't know why. They don't have a name for it. And they're aware that something's happening, but they find it, the person themselves too is like, as Vicky talked about, she was finding it difficult to work, and she was, and having these challenges and not knowing exactly why she was having that. And it really, that time is just, it can be very, very, very critical for families. They really do need to get connected to, a healthcare team and kind of reorganize themselves as a family around these changes.
Every realization is so important. That leads us to our next question of what are some of the challenges dealing and coping with Alzheimer's as the disease progresses, both for the person living with dementia and their families, and what kind of services are available to support them?
Yeah, well, you really did hear from Vicki and Robert and Rashad some of the challenges that they are facing. And there's just a lot of connectedness in the Johnson family. And, every family is different. So it really is families have to really shift their roles and their expectations of the person living with the cognitive changes. And some have an easier time of that than others. So you heard from the Johnsons how they're doing it. And then others may need maybe a little bit more support in making those shifts. It may not have the same level of flexibility. And so um, I see that a lot. I also see challenges around communication. Many people, you've been communicating with this person for decades in a certain way, and all of a sudden, because of the cognitive shift or cognitive decline, you're going to need, as a care partner, a family, you're going to need to change the way you communicate with that person. And that's easier said than done. And I say that all the time to families. This is easy for me to say this, but so hard to put into practice. But to stop with the logic and the reasoning and the, kind of arguing about something. It's not about what's right. It's about meeting the person where they are and their kind of emotionally. And so I see that as a huge struggle. So it's really the role changes and communication, I think, are some of the biggest challenges that families face over time. And the person themselves, they're becoming more dependent on others in a way they never had to before. And,
Right.
there's a way to do that. And families can also help them do that in a way that also focuses on their remaining strengths and abilities, and because there are so many there. I mean, Vicky, there's just so much, so many gifts that she has. And she was mentoring medical students and kind of showing medical students what it's like to live with a chronic illness outside of a clinical setting. That's a real strength and a gift.
Definitely a lot of insight there that you have provided. I know that in the webinar chat, there are questions. We are going to hold questions for a little bit later, but we will definitely have Dr. Morhart answer questions based on the line of questioning that I've just currently presented. So thank you so much for attendees who are putting in those questions at the moment. So thank you, Dr. Morhart. We are now going to move on to Dr. Shelley Williams. Hello, Dr. Williams. Thank you for joining us today. And so I will be asking from the perspective of a primary care provider a couple of questions for you to be able to expand on based on your experience, and then add any additions as needed during our conversation. So can you describe the interaction with patients in primary care settings who are encountering cognitive issues in addition to chronic disease, cardiovascular disease, diabetes, or high blood pressure?
Sure. First, I just have to thank the Johnson family again. It was incredible just hearing your story. And I think a lot of what you shared is what families feel going from that period of uncertainty and silence and, what is this, to you are empowered and you are living in hope and purpose and giving hope and purpose to others. So thank you so much. Thank you. I really enjoyed hearing your story. For your question, I think a big part of seeing patients in primary care who are living with dementia is a lot of people are living with uncertainty similar to the Johnson family and oftentimes living in silence. And some of our patients come in and they're like, is this just normal aging? Other times, people come in and they're like, this is not me. I'm different. What's going on? So you're going to get a myriad of the way that a patient may present. But I think something that's really important is what's going on as far as our overall heart health directly impacts what's happening with our brain and vice versa. When we have people with unstable heart disease or hypertension or diabetes that's not controlled, that increases inflammation and damage to healthy brain cells, which puts us at risk for dementia, primarily vascular dementia, but it can also increase our risk for other types of dementia, like Alzheimer's dementia. And the same thing can be said for someone living with Alzheimer's disease. When you're not able to manage your blood pressure, or take your medicines the way that you're supposed to, or if you're not keeping up with an appropriate diet for your diabetes or your hypertension, that directly impacts how stable you will be with your dementia. So the two go hand in hand. And a lot of people think just hypertension, diabetes, and cerebral vascular disease increase our risk for dementia, but even our overall oral health and what's going on with our hearing and our communication with others, that can directly impact our overall risk for developing dementia.
I think that it's really important, particularly the fact that you touched on oral health. I think that sometimes we're thinking about a lot of these coexisting chronic disease conditions, but there's a lot of all of this other layering, right, of when it comes to healthcare that may potentially impact the journey. So thank you so much for that response, Dr. Williams.
I was just going to add, when you mentioned about brain health, that was a very all-encompassing definition that you provided. And it's just as all-encompassing for our brain. Our brain impacts everything. So, the way that we're sleeping, the way that we're eating, if we're exercising, if we're challenging the brain, it all impacts our overall health.
Very comprehensive view and a lot of determination on the importance of holistic health, right, in that conversation. Another question that we have for you is, can you indicate your experience with patients encountering cognitive health issues inclusive of decline and the role of early detection?
I think just going back, everybody is going to come to clinic a different way. There are some people who come and they're like, oh, dad is just 80. That's why we're seeing changes. There are other people who come and they're like, mom was a school teacher and she was the most brilliant person that I know. What's going on? So everybody will come with a different idea of what's going on and a different level of willingness to know the diagnosis. But I think the important thing is getting that diagnosis, just as you saw with the Johnson family. It's an opportunity for your autonomy and independence as far as being able to direct your course and how you live and how you can potentially thrive with this disease. It's an opportunity for you to tell family and friends early what's going on and what you do and don't want to happen in your life. It's also an opportunity for everyone to understand what's going on. I love the way Rashad shared that he gained patience with mom, just knowing what's going on. And he learned new ways and styles of communication with mom because of what's going on. If you don't know the diagnosis, then it makes it hard for you to have that level of understanding and for you to make that change as a loved one. So knowing the diagnosis early is really about empowerment and understanding the individual and an opportunity to start creating that village as far as care, because this is a disease, as everyone has said, that you cannot get through on your own. You have to have family, you have to have friends, sometimes even hired caregivers. You have to know your community resources, everything from the Department on Aging to maybe participating in a day health program to becoming a person of empowerment like Mrs. Johnson. I hope you videotaped some of your talks, Mrs. Johnson.
So important and really like touching on the role of family dynamics, how that changes, right? You highlighted Rashad's, viewpoint and how that had to look like, but also, the support systems, the quantity of organizations that maybe one needs to reach out to, right, in order to be engaged through the process. So it was really multifaceted, the approaches that we need for individuals going through these types of experiences. So thank you so much, Dr. Williams. I'm going to wrap up, with the third question of, can you address how a cognitive evaluation helps to determine course of care and considerations such as the role of family and support system, which you've touched on a bit already?
Mhm. So I practice in a primary care geriatric clinic, but I also practice in a cognitive assessment clinic with a neurologist as well as neuropsychologist, social work, and myself as the geriatrician component. And I think one of the biggest things with that cognitive assessment is decreasing some of the fear and uncertainty of families as they come in. Really and truly giving someone an idea of what's going to happen and normalizing what's going to happen instead of making them feel like, oh, I'm doing all of this because I think you have dementia. No, there's so many different reasons why someone may experience cognitive changes. It could be everything from your medicines to imbalance in your thyroid to potentially mild cognitive impairment. So a big thing about the assessment is letting them know what to expect and then realizing that a big part of that assessment has to be looking at the person holistically, looking at the medication list, looking at whether or not they drink alcohol on a regular basis or if they're a smoker. Looking at whether or not they're having depressive symptoms, because that can sometimes present as cognitive deficit. Doing a paper and pen test to see how they're doing with different elements of cognition, everything from recall to learning new information to how they're utilizing language. We also do a head to toe examination, looking for neurologic changes. Could they have a stroke? Or could they have thyroid disease? Do we fill an enlarged thyroid? We sometimes will do a neural image with an MRI or a CT scan, depending upon what we're seeing as far as exam and history. And then Mrs. Johnson mentioned going through a lumbar puncture and getting CSF fluid to diagnose some biomarkers. We actually have evolved a little bit, and a lot of the biomarkers that we used to do through CSF, we can actually do through blood now. The all-inclusiveness I just mentioned there, a lot of that gets done within a cognitive assessment clinic. As far as in the primary care office, most people usually go through that initial pen and paper test and get the initial history. And then they're generally referred either to a holistic cognitive assessment clinic or to a neurologist or to a psychiatrist or a neuropsychologist for a more thorough assessment, sometimes even geriatrics. It just depends on the particular practice and the medical institution, which of those four might assess the patient.
Thank you for providing that comprehensive view, Dr. Williams. I think that it helps our participants today really get an idea. What does it look like from the lens of the clinician? Now we're going to move on to Dr. Rasha, who's going to level set the conversation of what does it look like on the research side of the conversation. So Dr. Shah, I'm going to invite you to speak on a couple of questions that we have for you. And can you speak on current trends in cognitive health research across the lifespan overall?
Yeah, sure. Thank you, Karen. And again, also thank you to the Johnson family and kind of highlighting in their own personal experiences the pathways people go through, including participation and research. I do think it's a really exciting time right now for what we're learning around cognitive health and interventions. But I want to start by a little bit going backwards. Like what we learn and how we grow together is a kind of a community activity. We need to take in the stories of what actual individuals living with cognitive decline that could be, eventually mild cognitive impairment or dementia are experiencing, and where they're needing that support, that help, that understanding to make the situation better. So we have to understand that pathway, and then we have to understand like what is that interaction that Dr. Williams was just talking about when the person comes to seek help into a health system and trying to understand like what we can do to diagnose things sooner, to start a treatment plan, and to support people as they go through this journey. And then at some level, when we think through it, we also have to think about a larger public health approach. Like, how are we going to get options available so we can prevent cognitive decline, maintain cognitive health? And if somebody does have cognitive decline or is experiencing a dementia, how do we get them to the point where they feel supported? And one of the messages at the end that the Johnson family brought up, that there's always a person behind this experience, right? Like it's not a number, and it's sometimes we get taken over by big numbers that we need in studies to understand things, but in the end, it comes to that personal. And I think in cognitive health, there's a couple of big steps that have happened over decades of work in this space of understanding patterns, and then seeing where the needs are and exploring them. So one has been summarized in the work over the last 10 years by the Lancet Commission, where they've taken all of the studies that have been done observationally. Like the Johnson said, they participated in an observational study where we're just asking questions and seeing how people are going through an experience over time, maybe not having an intervention that's being provided. But it's those observational studies that hundreds and thousands of researchers and participants have been engaged in over decades, have been helping us to understand what are some key factors that are associated over the lifespan with cognitive health. And it's important to remember humans live for 120 years at a max. On average in the United States, about 80 years. So this is very hard to study in one person. And because we live so long, right? So you have to build this up over time. But we're learning that this even in sort of the health of mom before she has the baby is important for health in cognition over a lifespan, including as you get older. We're learning that things about in childhood and early education and broader education makes a difference. And then what we're learning is that in midlife, factors such as maintaining hearing and being able to reduce things like high blood pressure and diabetes and cholesterol can make a difference in your cognitive health as you get into your 60s, 70s, and 80s. And then when people are in their 60s, 70s, and 80s, we're learning things such as maintaining eyesight and staying cognitively active are playing a role. And these were all observations, right? And like looking at them from individuals and then multiple individuals and seeing that maybe these patterns exist. But we've been in this interesting phase now of actually testing out interventions to try to help boost those activities up. Some involve medications, and there's a lot of work in that space to think about, are there medications to maybe maintain cognitive health? Some have been, and one example is like, blood pressure medications to control blood pressure earlier to hopefully help maintain cognition in the long run. We've been thinking about devices. People have been doing studies to look at hearing aids, right? Early interventions with hearing aids, will that help people maintain their cognitive health over time and reduce that risk factor of hearing loss? We've been thinking about then lifestyle factors. And non-pharmacological or non-medication or device interventions. And those are like, we've been trying one-off things like, okay, does this Mediterranean diet help versus another diet? and or does getting more physical activity, or how much level of physical activity do you need? Will that help you to maintain cognitive health? But really, now we're also starting to enter this point to maybe think about a combination of multiple lifestyle factors, maybe with medications, maybe with devices that can help people over time.
Definitely, there is a lot going on in the space, and like I really appreciate how you encapsulated all of that. Looking more into like specifics, can you provide a description of the U.S. Pointer study and associated findings, and maybe level set, about the U.S. Pointer study itself?
Yeah, and I think that builds on where I was finishing my last part of my discussion, which is how do we not test one item at a time when we know we might need a few activities to come together to help maintain cognitive health. And the US Pointer is building on a prior study called Finger that is trying to look at multiple lifestyle interventions to help to maintain cognition in older adults at risk. So let me back up and talk about the Finger study. That was the first one, and that was done in Finland about almost more than a decade ago. And in Finland, what they have is they have this sort of national registry, so they can follow people's health of everybody in a relatively efficient way. But they were the pioneers that started to think about what if we create a lifestyle intervention with some coaches that not only involves just making a change in diet and what you select with different food options, but also control things like blood pressure and heart risk factors, add socialization by doing group activities where people can come together, and add some cognitive activities where people are practicing different skills with their cognition to help to maintain those functions. And in that preliminary study in Finland, following people that had this intervention versus those that got regular care, they did find that individuals with the intervention did better in maintaining their memory and cognition on a standard battery we use of testing from different areas. So that triggered people wanting to replicate that to see if that was truly the pattern. And in the United States, the Alzheimer's Association led that effort and eventually got other partners like the NIH involved, and they launched the US Pointer Study. And the US Pointer Study was to take individuals that are encourage individuals to volunteer that might be having a family history of memory difficulties, noticing some subtle changes in their own memory, that they were not exercising that much. They were a little bit more sedentary in their activities. And they had when people were asked about their nutrition intake, there were areas for improvement in what they could eat and ingest to help. And so they took those individuals that met that qualification in multiple centers across the country, and they randomized them into two groups. One group was to get more intensive interventions with coaches online to help to learn about why it's important to do these lifestyle skills, but then to kind of guide them to making sure they did all of these things, like add more physical activity that they could measure with actigraphy that measures like your steps or something like that, with dietary intervention. They were asked to do 30 minutes of this computer game-like testing, activity. And all of these things packaged together was the main intensive intervention. And then they did a lighter intervention where they told people, like, these are important things you should do. Here's some information for you to use this and try it on your own. And after following people for 2 years after the intervention, they found both groups actually improved in their memory from where they started. But the group that got the intensive intervention improved a little bit more. And if they compared it to a historical group of people that didn't get any intervention, that group declined in their cognition on average in that time period. So it was one of the first studies released last year, top-line results from the United States, that showed this promise of using this kind of multimodal lifestyle intervention to help people maintain their memory and function. And now where that study is going is they're going to follow people that were part of the original studies longer to see how does that play out into developing mild cognitive impairment or dementia and maintaining that activities, after the intervention period's done. But they're also looking at ways like how can we scale this up so more people can participate in these type of interventions and this can be offered more often. So yeah, the pointer study has been a really quite remarkable addition to our knowledge and giving us more understanding of what could work in these spaces. There'll have to be other things, but it's a start to show that we can generate the evidence. And we're really thankful for the people who volunteer for those type of studies, right? So we can understand these patterns, learn what works, what doesn't, and use our resources and information more wisely when we meet, physician to patient in a clinical setting and they ask, what can I do? We can start saying some of these things.
Well, thank you so much for informing us about that conversation. And we have one more that actually has ties to health policy. So let me know. We have our colleague on the line here for the National Health Council on health policy. But this one has definite connections. So can you level set for participants the role of biomarkers and the implications for Alzheimer's dementia care? And if you'd like, at the end, we can have our staff member who specifically can speak on policy speak to that. But if you can open us up here on that conversation, Dr. Shah.
Yeah, I mean, again, just, as we've been doing these things on the lifestyle intervention, some of the other big activities over the last decade is can we better measure who might have this condition to make a better diagnosis? And the Johnsons talked about that, that they got a lumbar puncture and a test of their fluid for these biomarkers. These are just measures of proteins or other chemicals in our body that give us a signal sometimes that you're more likely to have changes in your brain that fit with Alzheimer's disease. And it could be for other dementias too, but the focus here I'm talking about is Alzheimer's disease. And so there's been a lot of work to try to understand, can we identify these biomarkers and can they be accurate and reliable? And now some of them have come into existence commercially, FDA approved. In the particular scenario that you've had memory problems, you've talked to your doctor about it, your doctor has diagnosed you as having mild cognitive impairment. That's like cognitive problems that are present, but you're still able to do your activities of life, but we're noticing these cognitive problems. Or dementia. You've been diagnosed with mild cognitive impairment or dementia. Dementia meaning I'm having these cognitive problems, but now they're affecting what I do day in and day out, like at my work or with my hobbies or other activities. So you have to be diagnosed, right? And then the biomarker is ordered to see if the cause of that cognitive decline causing a diagnosis is due to factors associated with Alzheimer's disease. And then that will trigger people to go for further evaluation for some of the treatments we have available. This is a very fast changing field, and things become available sometimes. There's a tendency to want some people to get before, but there we don't know right now what can do to intervene. The research is moving fast in that space, and I'm sure in the next year, 2 years, 5 years, we'll have better answers about what to do if you're having cognitive, you're cognitive normal, but you have a family history, and should you get this biomarker, what does it mean, and what do we do to intervene? But we're still at an early stage. So, but yeah, I would turn it over if a person on the staff with the policy wants to describe how we're still working through protecting people that get this test so that it's used in the right way and it's not used against them.
Okay, so can I invite Jennifer Dexter, the Vice President of Policy for the National Health Council, to speak on that?
Sorry about that. Took me a second. Hi, I'm Jennifer Dexter. I'm the Vice President for Policy and Advocacy here at the National Health Council. And Dr. Shah, I think you hit it right on the head. Policy is trying very hard here to keep up with the science. There is a lot of debate around kind of two frames of that. The first is access. Who, where, and when are we going to provide access to new tools in ways that is helpful and educational and appropriate, but also coverage issues. What, when and where are they going to be covered? What steps are we going to have to go through with that? This is Jennifer speaking. I think there is some hesitancy to dive in, and because the science is moving so fast, by the time you figure one thing out, there's a new advancement, and there's such a clamoring for access and coverage. And the progress has been incremental, but it's been very real. But what are people who are outside of that cadre of folks that it might be helpful for or address when they're reading headlines around, new breakthroughs and how that moves forward? So I would leave it at that and just say that's really the policy conundrum we're in right now, is kind of trying to make sure that the policy is appropriate, keeps up with the science, and doesn't get outpaced by it and doesn't lag behind. They're not doing the best job in the world, but but it's a very complicated issue, and so not surprisingly. So I'll leave it at that. That's helpful.
Well, thank you so much, Jennifer, for being able to join us today. I'm also going to include some recommendations. So Dr. Shah recommends for further consideration that it's important that patients and families also ask the following questions about research participation. And that includes, were you approached to be part of a research study? What factors played into your decision to volunteer or not? Would you search for information on the latest research funding or have families send you information? How do you make sense of all these research findings? And does that, encapsulate, your thoughts, Dr. Shah?
Yeah, I mean, I just encourage answers together by working together in these spaces that are complex and moving fast. And I hope you get the opportunities, or in your constituencies, that there are people that you represent, that we just encourage that they participate or have an open mind to volunteer to be part of research studies. They can always say no, it is voluntary, but to ask, to search, like I think the Johnson family said, using technologies to look for what opportunities are there to participate in research, and to be a voice and learning through that process, so that we can all improve. And that's probably one of the bigger changes that's going to happen, I think, is we're realizing that what is happening in the Alzheimer's disease space is affected by many other conditions people have. And what's sometimes good for research in cardiology will also be good for research in Alzheimer's disease. So, please just, ask about being part of a study in whatever area or condition you're interested in, and hopefully that will keep building our knowledge and how we maintain cognitive health over time.
Thank you so much. So now we're going to move on to the next part of our presentation, which is the call to action. So where do we go from here? So that includes a variety of different items. So that includes developing a proactive, individualized plan to protect, strengthen, and maintain brain function through evidence-based habits, support systems, and community engagement. It also includes encouraging collaboration and pooling of resources, right? So we heard about that in our panelists speaking today, starting with wraparound community projects and assisting individuals living with dementia and other forms of cognitive impairment and their family caregivers. Jennifer Dexter spoke on supporting policies and programs, right? It's really important. This is a very evolving space and ecosystem, so that is important for us to think about what does that involve in terms of improving access to mental and cognitive health care. And lastly here, I've included the Healthy Brain Initiative. We've spoken a lot of the initiatives on the Alzheimer's Association. This was done in conjunction with the CDC that promotes a public health roadmap to maintaining cognitive health through education, policy, and intervention research. So we are going to move on now to an example. So Dr. Williams spoke to a lot of that intersection with cardiovascular disease, and cognitive health. And this is yet another example on how cognitive health is linked to chronic disease. So here we see an article coming from American Heart Association, and it shows how cognitive health can impact many patients in the cardiovascular space. In the American Heart Association findings, heart failure, atrial fibrillation, and coronary heart disease were linked to cognitive impairment. So I want to just provide for all of those participants here a clear example of how that looks like when we intersect in other spaces, for example, in the chronic disease area. So now we are going to be moving on to our last portion, which is questions and answers. I know that there was a question here that was provided by an audience member on the Alzheimer's space. So I just want to make sure that we get back to that before we start moving on to any other questions. And please post individuals. If you have any questions that you may have, if you submitted questions in the question and answer, we will get to as many as we can. If you would like to ask your question aloud, please raise your hand and our team will unmute you. And if we don't have time to cover your questions, you may contact me directly at Karen Mancera Cuevas at nationalcouncil.org, and I will respond directly after the live event. So let's move on to here to see. So we have a question here. Have you given any consideration to including other disease states that affect brain and cognitive health? For example, benign brain tumors is a question that we see, or also looking at long-term effects of brain radiation. So if any of our panelists would like to answer that question.
I'll take a stab, and then Raj, if you want to also. But a lot of the patients that we wind up seeing in the cognitive assessment clinic are patients who have been former cancer patients, especially with breast cancer and brain mets who have had radiation in the past. They actually prophylactically treat a lot of these patients with many of the drugs that we use in patients who have dementia. Memantine, which is commonly used for patients with Alzheimer's disease, middle stage to late stage. We use it a lot in patients who are undergoing radiation therapy for breast cancer with brain metastasis. Other conditions that you mentioned also atrial fibrillation, patients who present with other chronic diseases, whether it's COPD or someone with osteoporosis, any chronic disease that limits someone's mobility, that limits someone's interaction with other individuals, can put us at risk for developing dementia. Yeah.
Yeah, and I think that's a good point that the person who put the question out there is, and that's why it's a little bit complex, right? With anything about cognitive health, is our brain is, it affects many things and it's affected by many things. That's part of the art a little bit, and that's why the clinical evaluation is so important. Because there are multiple conditions that can kind of lead to the same outcome, which is a reduction in cognitive health. And trying to understand that, like we can do some things in general, like everybody should do to help cognitive health and build resilience. But then there's going to be specific things we have to understand for particular conditions so we can tailor intervention to the exact person. And, I think we're entering that era of sort of precision cognitive health, where we're not only understanding like what we can do in large scale with, everybody on average, but we're trying to get closer to like, how do we understand you and what your makeup is as a person that's experiencing cognitive decline, and then find a treatment regimen that will work for you. And one that's not just medication again, right, or a device, but one that is more holistic in its approach.
We also have another question here, just to go quickly of like thoughts on, do you find that there are other diagnoses that tend to go hand in hand with Alzheimer's and dementia? And how does that reflect in work with families? Very interesting question, because Darby, I think
Yeah.
that touched on a lot of what you were talking about, but also Dr. Shaw and Dr. Williams.
Yeah, and maybe I can answer, and Darby, you can answer this one a little bit, and Shelley, add anything you want to here. But what struck me is even listening to the Johnson story, right? Like when one of the first treatments that was offered to her, right, as she was experiencing cognitive decline, was depression medication, right? So it is very common. You see, some mood issues coming up, like depression, anxiety, at the same time that people are developing decrease in cognitive health. So that's one example, right, that we could listen to in that story that the family presented to us in their experience. But others can comment. Yeah.
I think the underestimated thing is polypharmacy, multiple medications in an individual, especially medicines that they were on in their 30s and 40s and now they're 80, may not be appropriate medicines for them. So multiple medications in an older adult can predispose to cognitive changes that look like dementia. And then also the hearing loss. The hearing loss is huge, and it definitely sometimes presents looking very similar to dementia, as well as imbalances in our thyroid hormone and vitamin levels like vitamin B12, even our vitamin D levels. If those are off, that can present as a lot of fatigue and confusion and difficulty with concentration. So many other chronic diseases can definitely present looking like dementia and always should be considered and ruled out. And definitely impact communication with family.
I don't have much more to add than this, but it's, it's just good medical practice. Of course, I'm sure that Shelley and Raj would agree that you're going to look at everything. You're going to be not just focused on what's happening in the brain, but that you really are taking this holistic look at the person and their past history, medical history. And then in terms of my role, I'm really looking at their psychosocial history. I'm not just looking at this family at this time of their life, but how have they been coping and living as a family for all, 4 years. So I want to get to know them a much more in depth. So I think that that's just good social work practice, good medical practice, that you really look at the whole person.
We have another question here asking about the biomarker test itself. Is that identified through blood? Is there a less invasive test? Is it as opposed to spinal tap?
Yeah, I think, Shelley, you brought this up in your discussion a little bit too, and it's, there was a time where people would say the only way we could, prove that we made a diagnosis of Alzheimer's disease or dementia was to see it on brain tissue right after somebody's died, and that was the gold standard. Now we've moved to, like, in the last 20 years of this work in biomarkers, we moved to like imaging studies of the brain, and using special tracers like a PET scan. We've used CSF fluid and taking that fluid from that bathes the brain to be able to examine for proteins and items. Those are, they take time, they take energy, they're costly. They have some rich benefits to them. So there's been this like kind of movement to like, how can we figure out a blood-based biomarker, something that we all have done, right? Which is have our blood drawn for different tests. And that's kind of the area we're in as one of the more less invasive ways, hopefully more scalable across the world. And hopefully but we need to, I think there'll be more biomarkers in a term, biological constructs. We people have been looking at things, like how people's language when they're talking on their phone and how that changes can be a marker of cognitive change. So we might find digital markers, right, over time, that will also help us predict. So it's a very fast moving field and how people are thinking about it. But the biggest drive is, can we make it simpler, easier, more helpful to us, for more people to get health and to achieve better outcomes. And a biomarker does different things. Sometimes it's used to predict who might get a condition. Sometimes it's used to diagnose a condition. Sometimes it's used to follow a condition to see if treatment is working. Not one marker will do all those things sometimes.
So any other thoughts?
No, Darby and Raj, I was just going to take a stab at Cynthia's question because I think it sort of tags on to what Raj just said. Her question was about patient access and appropriate referrals are the key to getting comprehensive medical assessment. And I totally agree. Biomarkers are not available to everyone. They're not available in every single clinic. And that in some ways is a good thing. And I mean a good thing in the sense that that all-inclusive evaluation really and truly needs to occur, dependent upon what is the age that the person's presenting, what are some of the signs and symptoms they're having. Is this Alzheimer's dementia or is it an atypical type of dementia? Which will really predict, is this someone who needs referral to a more comprehensive assessment in a cognitive assessment clinic. So I agree with you. I wish we did have access to everyone, but I think to make the access more global, we really need to consider, what are we seeing in front of us in primary care? What age is this person? What are their symptoms that they're presenting with? And are they someone who might benefit, from some of the newer therapies like monoclonal antibody therapy? Or is this someone who's not going to be appropriate for that therapy? Hence, do I really need to do biomarkers at this time with them? So I think a lot of things have to go into the consideration.
All right, I want to close us off with focusing on the Johnson family on their final thoughts as we are concluding our conversation today. So Johnson family, any thoughts based on the questions that were posed today?
I think everything was very helpful, especially the last portion of it. Thank you, everyone, for your comments and everything. But yeah, I just thought all the different approaches were interesting, and I appreciate you all for sharing that information.
All right. So I want to thank all of you. Any other comments?
Yeah, just the different Dr. Williams when she made comments or assessments about what are the some of the causes for cognitive decline, and it could be medical, it could be a combination of medicines and things like that. So that was an eye opener for me to hear that. And also, just one last thing about Vicky, she and someone spoke about it, is the researchers and the doctors, they're doing everything to bring awareness to this disease. But I think for Vicky, she's taken a more personal approach. She's trying to get the information and the awareness out to friends, family, and community. And that's kind of like a personal mission for her. So, and I'm going along with her for the journey because that's her mission now. That's her purpose. And that's what we're trying to do. So that's what this Johnson family is doing. So thank you.
And we are going to be wrapping up our presentation right now. I want to thank our incredible panel, Dr. Morhart, Dr. Williams, Dr. Sean, the Johnson family for joining us today. We would also like to thank our sponsor, Eli Lilly and Company, for sponsoring today's event. In addition, we want to recognize the National Health Council staff managing the webinar platform today, including Leah Spencer, Carissa, Raquel, for your support. We want to thank you for your time and attention. I hope the session has given you a clear perspective on the realities of cognition and the role this plays with patients, researchers, and clinicians. My contact information is included in addition to a post-survey QR code. So the exact survey we did at the beginning will be the exact survey that we're going to be doing right now, which should take less than a minute to complete. Please do that. And I want to thank all of you for your participation. If all of you can hang on for 1 second, attendees, because then we will be spotlighting the signs of patient engagement. So we may just want to just move on to those slides right now. So the signs of patient engagement is the National Health Council annual summit that focuses on research and programs. We have a variety of speakers. We are including in the chat for those who are interested to please join us. This will be in Arlington, Virginia, May 11th and 12th. We have so many featured keynote speakers here included. So also want to plug that in. And we are running to deadline for registration. So please, please register as soon as possible. And I have also included schedule at a glance. So I'm concluding today's presentation and thank all attendees and panelists for their participation today. Thank you.